Hi, I'm Dr. Muthanna Alrawi, consultant urologist and andrologist at Canadian Specialist
So,
Hospital.
welcome everyone. Thank you for joining us for today's webinar. Anavara is leading provider of medical wellness and health facilitator. We provide medical tourism across the globe. Today we are presenting webinar on prostate cancer, presented by Dr. Muthanna Alrawi. He is a renowned board-certified consultant urologist and an andrologist in Dubai, with follow-up training from Germany. He earned a board degree, the highest degree in urology specialty. He has been awarded in minimally invasive surgery by the World Association of Laparoscopic Surgeons. He has been extensive experience in specialty of urology, including endoscopic urology. Welcome you, sir.
Hi, everyone. I am Dr. Muthanna Alrawi. Thank you for this presentation for me. And I'd like today to present in brief about the prostate disorder that may affect the prostate, including the benign enlargement and inflammation and also prostate cancer. So now I'll start the presentation. In the slides of presentation?
Yeah, we can see the presentation very well.
Okay, good. So the prostate is a walnut-sized gland, about 20 to 25 gram, located between bladder and the penis, one of accessory gland of urinary system. And as you know, that its function to secrete part of the fluid that nourishes the sperm. This prostate gland may be affected by the following disorder: benign prostate enlargement, prostate cancer, in addition to inflammation and infection. Benign prostate hyperplasia is non-cancerous enlargement of a prostate, is the most common penile tumor found in men. It causes lower urinary tract symptom that we call LOTS. It is two types, either irritative or obstructive. The irritative urgency, frequency, nocturia, and the urge incontinence. Obstructive hesitancy, intermittency, streams, training, prolonged micturition, feeling incomplete, emptying, and dribbling. The symptom, we can, for every patient, evaluate the severity of these symptoms by a special score we call the International Prostate Symptom Score. And according to his suffering of the last month, we can evaluate. Then after answering that questionnaire, we will, at the end, we get roughly estimation of his suffering from lower urinary tract symptoms. So we divided by mild, moderate, severe according to that score. And according after evaluation the symptom, then we can start the management of the benign prostate. So most important in the LOTS and the enlargement of a prostate, to know is these symptoms suffering the patient. We ask the patient he can continue his life with these symptoms. It will be level of the satisfaction of if he can live for all his life with that symptom. So not the matter of only enlargement. If there is only enlargement and there is no other symptom, there is no need for treatment. So first question that after evaluation, we ask with the patient if there is this symptom bothering him in his lifestyle. Then accordingly, we will start the treatment of benign enlargement. So first of all, we start with medical treatment, focus if we can treat him as a medically before going to the surgical management. And we ask which most common the complaint that bothering him. So if it is nocturnal polyuria predominant, so that we will divide for another part. We will give the treatment accordingly. And if there is a storage symptom that we say yes or no, then if it is a prostate, the second one, prostate volume, is it less than 40 or more than 40? So if it is only polyuria, nocturia polyuria, that is nocturia and a lot of urine output, more than the third of urine. So we start by education, lifestyle advice, with or without vasopressin analog. If it is storage symptom like irritation, frequency, urgency, so we will start with also education, lifestyle, avoid spicy food, avoid caffeine drinks, and with or without muscarinic receptor antagonist or beta 3 agonist. So that if it is storage. If it is not storage, that means it is obstructive symptom, urination symptom, difficulty, intermittent urination. We first divide, if we check if prostate volume more than 40 or less. If it is more than 40, so mostly that you need long-term treatment. So we start with 5-alpha reductase or minus 5-alpha blocker or BDE5 inhibitors. If it is less than 40, so we go also education, lifestyle, and we can add muscarinic receptor antagonist or beta 3 agonist, and also if in addition to the alpha blocker. So if it is less than 40 gram, we start with, and it is obstructive symptom, we start education, lifestyle, and with alpha blocker or BDA5. And if there is still residual, some storage symptom, in addition to the obstructive, we can add the anti-muscarinic, muscarinic receptor antagonist or beta 3 agonist. If there is no bothering symptom, only enlarged prostate, so we can just watchful waiting with or without education and lifestyle advice. So now this is the medical treatment according to the, as we say, to the International Prostate Symptom Score, and we, in addition to bothering these symptoms, and also the prostate size and the type of the symptom that's suffering. So as we said, if it is more than it is nocturia or polyuria, we start with vasopressin with lifestyle. If it is irritative symptom, we start immediately antagonist, muscarinic receptor or beta 3. If it is a difficulty in urination, we call urination symptom, voiding symptom. So we start with 5-alpha blocker or BDE5 inhibitor, and we can add later, if there is some residual storage symptom, we add anti-muscarinic receptor and B3 agonist. This is medical treatment. So now there is some absolute indication for surgery, or if they are not responding to the medical treatment, or those who do not want medical treatment. So we can, these three, we can say these three indication, either failure of medical treatment, or there is absolute indication for surgery, or not responding to the medical treatment, or want, some patients want immediately to go to the surgery. They don't want medical treatment. So if we choose the surgical treatment, so we have to divide the patient according to the risk patient. Risk patient being comorbidity, or if there is any other cardiac or any medical issue. So we have to divide to choose which better it will be good for him. So now if suppose no high risk patient, so we, according to the prostate volume, we will according to prostate volume, we will choose which appropriate. If it is less than 30 ml, so it will be 2IP, only incision of bladder neck, or 2RB, or if it is 30 to 8, if it is the volume 30 to 8 gram, will be 2RB will be the first first option. There are also other alternative like laser inoculation, bipolar inoculation, or vaporization, or prostate urolift. If it is more than 80, so we will go for either open prostate or HOLIP or bipolar. This is the first option if it was more than 80 gram, the size of the prostate. We can also the second option, if that's not available or no experience, we can also go. other option also, if there is can have surgery under anesthesia, if he high risk and he can't do surgery under anesthesia, we can give prostate urolift, and it is minimal invasive technique. We can do it even without anesthesia under local anesthesia. So this is summary about enlarged prostate, and that now two novel treatment we have also here at Canadian Hospital. This is the urolift. We can do it as a 15-minute procedure, even under local or transrectal anesthesia, and we can proceed. It will take 15 to 20 minutes and with good result, especially for prostate less than 70 with no middle lobe. As this form, we enter by the cystoscope and will put some clips, 4 to 60 clips according to the size, and we will open the channel, and this will relieve that obstruction. The second, also minimal invasive, also the same. We can use it. It is resium therapy. That also it will take also 15 minutes, 10 to 15 minutes. By also under local anesthesia, day case, patient will be discharged the same day, and also by special machine we enter to the prostate, and we give in a special area by needle. We do vaporization by water to the certain area, and that it will need to be absorbed by the body, so the patient will get full response about 2 months to 3 months. He will get the full benefit from these procedures. So now this is in a brief about the enlarged prostate and the medical treatment and surgical treatment, and also the new technique, that minimal invasive technique. So if you have any question about the medical treatment or surgical treatment, I am ready.
Folks, I hope your knowledge has been expanded by this webinar. Now it's time for your questions. If you have any questions, raise your hand and you can ask the doctor one by one.
Or we can proceed, up to you. How can we? So now I think we can proceed. Then if you have any other question, we leave it to the end. Okay? It's okay?
Sure, sir. Let's proceed with the presentation, and people will ask the questions at the end of the webinar.
So now the second part of the webinar is prostate cancer. We will talk also in a brief about that one. Prostate cancer is second most commonly diagnosed cancer in men, with estimate 1.4 million diagnosed worldwide in 2020. The incidence of prostate cancer vary widely between different geographical areas, being highest in the Australia, New Zealand, and North America. And also there is relatively less variation in mortality worldwide, although the rates are generally high in population of African descent. Risk factor and chemo prevention. Familial relative risk increase according to the number of affected family, their degree of relatively and age at which they are affected. Also, if there is PRCA associated cancer, especially type 2, are more likely to present with high-grade, locally advanced and metastatic disease, and have poor cancer-specific and metastatic-free survival after prostatectomy. There is no clear association between it and the prostate cancer risk. Obesity will be high rate of biochemical failure after treatment. Prostate cancer, second most common cause of cancer death in UAE. globally second most common cancer, fifth leading cause of cancer death, and also racial disparity in prostate cancer. African American have 76 high incidence and secondly high cancer-specific mortality rate than white men. The incidence of prostate in other ethnic group is lower than that of white and African American. Difference in the treatment pattern explain half of the cancer-specific survival. So now, the most important in the prostate cancer is the early detection at the stage when it is we call confined disease. At this stage, it will be highly curable if we detect the prostate cancer in the early stage, and it will be there's no metastasis or locally advanced. So the screening and early detection important, but the other issue, there may be some over treatment because the variation in nature of prostate cancer, maybe it will be indolent and it will not be progressive. Other types may be so aggressive. So first, we will not do screening for all the people, all the men, but there is some criteria that we do a guideline for screening and early detection. So we offer individualized risk-adapted strategy for early detection to well-informed men and life expectancy of at least 10 to 15. So if it is life expectancy less than 10 years, no need for screening. So we offer early PSA testing to well-informed men at elevated risk of having prostate cancer. So those people, we have to do the PSA screening to detect early stage. Those include men from 50 years of age and above, men from 45 and family history. So any patient has family history, you have to start the screening from 45, not from 50. The other men, 50. Men with African descent, also from 45, because the incidence will be start early. For men carrying PRC2 mutation from 40 years of age. So these four type of people, we have to apply the early PSA testing to detect early stage prostate cancer, and that will be cured. So early diagnosis of prostate cancer on life expectancy and performance status. Men who have life, as we said, less than 15 years are unlikely to benefit. So I think this is important to focus on this point. Clinical diagnosis, prostate cancer usually suspected on the PSSD, digital rectal exam and or PSA. So both those suggestive. So if there is any suspicion, we have to go to do definitive diagnosis on the biopsy by histopathology verification of adenocarcinoma in prostate biopsy core. Now, after diagnosis, the most important to divide the patient to three category: low risk, intermediate, and high risk. This is especially in early stage after diagnosis, because that will affect our treatment decision, how we will decide which treatment will be appropriate for the patient. So this is important to categorize after diagnosis to low risk, intermediate, and high risk, depending on the PSA and the Gleason score, that it is the biopsy, and also on a clinically, they are by clinical examination, how it will be detectable or not detectable. So according to these three, we divide the patient, and then we will decide which treatment will be appropriate. Because as we say, the prostate cancer has a variable course. It may be indolent, it stay for a long time without doing anything for the patient. Other side of the spectrum, it may be so aggressive. So most important after diagnosis to divide the patient to know in which category. Then we will decide according to the management. Management, we have four types of management. First one, deferred treatment. It has active surveillance and watchful waiting, radical prostatectomy, radiotherapy, and hormone, immune, and chemotherapy. So from these four options, we will choose which appropriate to the patient according to his risk group. So here, as a guideline for recommendation for various disease stage, we start with low risk disease. Active surveillance, it should be that concept. It means we just check the patient by doing PSA, by doing repeated examination and MRI or biopsy according to some criteria. But we will not do any intervention unless we see there is some progress. Then we apply the curative option. So it should be the patient more than 10 years and low risk disease. So if it is high risk, there is no role for active surveillance. Only for low risk and a special type of low risk, we can apply the active surveillance. So that will depend on taking biopsy, and we confirm the biopsy, and it should be low volume disease and low risk, so we can apply that one. Active surveillance. Active treatment, that now we are just only talking about low risk. We can also active treatment, we offer either radiotherapy or we can also do open, either surgery as an open prostatectomy or radiotherapy as alternative to the radiotherapy. This also we can choose with after consulting with the patient about which his option or his preferable. Also we can discuss that with the patient. So either if low category, either we choose low risk, either we choose active surveillance, or we do prostatectomy or radiotherapy. No role for hormonal therapy. This is important. No role for hormonal therapy in low risk group, and is asymptomatic, so no role for hormonal therapy or chemotherapy. Okay. Also, if we do prostatectomy, no need for doing lymph node dissection. Only we remove the prostate. Radical prostatectomy. Intermediate, there is special category that it should be pattern less than 10%, PSA less than 10, and clinically very low disease. We can accept to apply active surveillance, but it should be motivated patient and continue with regular and strict follow-up. Otherwise, we can go to radical prostatectomy, but also it should be a life expectancy more than 10 years. We can also offer nerve-sparing surgery that we remove the prostate, but we keep the nerves for his performance, important for if there is no low risk of extension outside the prostate. Also, we do extended lymph node according to the some risk. Other option also, we can apply radiotherapy. This if prostatectomy not available or there is no experience, we can also choose the radiotherapy two type. We can choose either external beam radiotherapy, or we can choose brachytherapy, or combination of both. And this also we can start to give in the intermediate group a course of the hormonal therapy with the radiotherapy of 4 to 6 months only. Now, high-risk localized disease, we can, that one either radical prostatectomy if high-risk localized as part of multimodal therapy. If we choose radical prostatectomy in high risk, we have to add other things. The radical prostatectomy will not be enough in high-risk patient. Yani either we give radiotherapy or hormonal according to the special protocol. And also we do external pelvic lymph node dissection in high risk. Radiotherapy the same. We have the option either external beam or brachytherapy or both. But in this case, in high risk, we have to do hormonal therapy in addition for 2-3 years. In the intermediate risk, 4 to 6 months. In high risk, 2-3 years. So this is the high risk and intermediate and low risk. This is in a brief about the option that available. Radical prostatectomy, there is many approach, either open or laparoscopic or robotic surgery. Also locally advanced. This is part special type of high risk that locally advanced. This is not confined. This is the percentage or the probability of the cure, it will be less. So also we do radical as part of multimodal therapy, and also the same we will use also radiotherapy, either external beam with boost dose of brachytherapy, and also at least 2 years from hormonal therapy, it is androgen deprivation therapy, it should be with the radiotherapy. So by this division, in a brief, we diagnose the case, we classify the patient according to the risk groups, and from this group, we decide which option we can select according that to be fit for life expectancy, about the performance, about the risk group. Now, the last case now, if it is metastatic disease. Metastatic, there is no hope for cure the patient. So the management will be palliative treatment in the metastatic disease. This is the difference from prostate, we call prostate cancer confined or even locally advanced. There is hope of cure the patient. When it becomes metastatic, this is just to palliate the symptom and also reduce the risk of potentially serious sequel of advanced disease. So we start immediate systemic treatment. We offer antagonist, LH antagonist or orchiectomy before androgen therapy. And the treatment for metastatic, we start with hormonal therapy, androgen deprivation therapy. So, and also for all patients with M1 disease that metastatic, even if they are asymptomatic, we have to start early systemic treatment by androgen deprivation therapy. We do not offer just androgen antagonist monotherapy to patients with M1. It should be also LHRH agonist or antagonist to block or orchiectomy to block the main stimulator for growth, that testosterone, the main part in the body. We have to block it almost completely, not only but only androgen receptor antagonist. And also in addition to the androgen deprivation, we have to add some systemic therapy with all M1 patients. We can also offer this is systemic, either in the androgen deprivation, we have chemotherapy, docetaxel, who are fit for docetaxel, or we can also abiraterone acetate plus prednisolone, or ablotomide or enzalutamide to the patient whose first presentation M1 disease and who are fit enough for this regime. So the main, it is androgen deprivation therapy in addition to other systemic therapy in all M1 disease. Also, sometimes we offer androgen combined with any local treatment to patients with high volume M1 disease outside the clinical trial. So after, now this is the stage we said, low risk, high risk, and intermediate risk, and metastasis. There is one issue after controlling in this before the metastasis. When you remove the prostate, we get some category called biochemical recurrence after radical, or biochemical recurrence after radiotherapy. We control on the tumor, but after that only we see the PSA will increase, but there is no metastasis. This we offer monitoring including PSA and early salvage immunotherapy to all men with 2 consecutive PSA rise. If 2 times happened rise after radical prostatectomy, you have to start radiotherapy. Also, we do not wait for PSA threshold before starting a treatment. Once the decision for radiotherapy, we have to start. We offer also hormonal therapy in addition to the main. We continue the hormonal therapy in addition to the radiotherapy. If it is increased after radiotherapy, also we have to monitor, only offer radical prostatectomy, brachytherapy, or cryoablation to highly selected patients with biopsy-proven local recurrence. So after radiotherapy, we have to do biopsy and the proven recurrence, then we can put some local treatment. There is also systemic treatment of castrate-resistant disease. Some cases after giving metastasis and we start hormonal therapy, they start escape from the hormonal therapy. So we have to give some systemic treatment as a palliative treatment. So we base the choice of a treatment on performance status, comorbidity, location, and extent of disease, and patient preference on, and also on previous treatment for hormone-sensitive metastatic. So these we can choose from this option: cabazitaxel, docetaxel, enzalutamide, and olaparib. This medicine we can choose it according if patient reach to the systemic castrate resistant. Castrate resistant, it means we give hormonal therapy, but he's in spite of that he shows some progressive in the either BSA or also clinically. So we can offer cytotoxic therapy for they are and are chemotherapy naive docetaxel, or we offer patient with metastatic castrate resistant, and the progression over the toxin, we can give further life prolonging a treatment option, which include cabazitaxel, enzalutamide, radium, and olaparib in case DNS homologous recombination repair alteration. And we base further treatment decision on metastatic on also the same performance, previous treatment, comorbidity, and extent of disease. We offer abiraterone or enzalutamide to patients previously treated with 1 or 2 lines of chemotherapy, and make some alteration. If he is on chemotherapy, we go to the abiraterone or enzalutamide, or if he's an abiraterone or enzalutamide, then happen the progression, we go to the chemotherapy. Avoid sequence of androgen receptor targeted. And if he is okay in abiraterone, if he had resistance, don't go to enzalutamide because it will be the same. So we have to choose chemotherapy. As I said, offer chemotherapy to patients previously treated with abiraterone or enzalutamide. And cabazitaxel to patients previously treated with docetaxel. If he on docetaxel and shows some castration resistance, we have to shift to the cabazitaxel. So this is in a brief, the steps of the treatment of the prostate cancer and also for enlarged prostate. And I hope that I give some information in a brief about these 2 cases. Thank you.
Thank you, Doctor. Doctor, Mr. Dalip wants to know what should be frequency for PCA test after the age of 70?
Yeah. As we say, the life expectancy important. So if it is, as we say, more than 10, we have to offer this. After 50, we can give. So according to the risk factors, here, if it is the man with PSA level more than 1 nanogram, this is suppose he came at age 40 and he was PSA more than 1, we can make it follow up every 2 years. If he is 60 and above and he has more than 2, so also from according to the recommendation every 2 years, 1 to 2 years according to the level. And if it is 2 or 3, we can say it every 2 years. But if it is in the borderline 4 to 10, we can make it annually. Clear? So after 70, according to the level, if it is more than 2, at least with follow-up interval of 2 years. Yes, at least.
Okay, doctor. Folks, do you have any questions?
Yeah, Banga, please ask the question.
And hello everyone, my name is Benga from Nigeria. I want to confirm, or I want to talk about UTI, untreated UTI. Can it lead to prostate cancer? Untreated UTI, can it lead to prostate cancer?
What about prostate cancer? Can you make the voice clear, but please?
A doctor is asking whether UTI can lead to prostate cancer.
We do what?
UTI can lead to prostate cancer.
No. The UTI will not lead to the, in general, UTI will not lead to prostate cancer, but some theory that in chronic inflammation in the prostate itself, it may cause prostate cancer, but otherwise, if it is in the bladder, in the urethra, in the kidney, there is no correlation with prostate cancer.
Okay, thank you, Doc.
Hello.
And doctor, according to some study, it shows that African descent of black people gets prostate cancer more. What is the reason behind it?
What is?
African or black people get prostate cancer as compared to the other descendants. What is the reason behind it?
This is genetic cause. They have in the USA, the African American, they notice that they have more incidence of the prostate cancer and also mortality a little bit higher. So even by the early detection, we have to start from 45. The other races, we have to start 50 years. But for them, we should start from 45.
Thank you, doctor.
Yeah. And genetic predisposition.
Yeah, Mr. Abashir, please ask the question of the doctor. Guys, if you have any questions, please ask him rather than raising the hand.
Sorry, another question, sir.
Yeah.
What are the causes of prostate cancer? What are the causes of prostate cancer in men?
What are the causes? You are saying what are the causes of prostate cancer?
Yes, sir. Yes, sir. What are the issues that can lead to prostate cancer?
Yeah, we say in the.
You get my question?
Yeah. The causes first. If there is family history, this will cause one of the causes of that one. Also, there is no clear causes evident why some patients get prostate cancer, why the others. But there is some risk factor in general. We call it familial. So some family, they have relative higher risk, even they get in early age, they get that one. Especially if there is multiple relative, like if he has father or grandfather or more than 2 brothers or even a cousin, all that will increase the risk. This is one of the causes. Another group, if there is some mutation in the gene, especially in PRC2, some syndrome or hereditary issue that make a mutation in that gene and lead to the increase the risk of getting the cancer. Other causes like obesity just make higher rate of biochemical failure, but it is not direct cause. Also, many research have happened to see if there is any relation with diet, but there is no relation of diet with that one. So it is mostly a genetic issue or some mutation that will lead to that one. Yeah.
Yes. Another question: can a diet?
The diet, there is some theory about some diet may give some protection or give help, but it is not.
A diet, can a diet lead to prostate cancer?
No, the diet will not cause prostate cancer. There is no relation, as I said, no clear association between even dietary fight intake or prostate cancer. But some diet may give some protection. So if it is high rate of vitamin D, they said it may give protection for prevention of prostate cancer. So person who has low vitamin D, this may subject them more to get prostate cancer. So prevention, we can give vitamin D. Also, some food like pumpkin, also it may give some protection. Lycopene that it's present in tomato, it also, some theory, they said it gives some protection from prostate cancer.
Okay, thank you, sir. I think one of the doctors...
More vitamin D.
I think one of...
Yeah.
Yeah. I think one of the doctors is trying to talk. He's raising his hand.
Pardon?
Dr. Kadai, can you talk, please? Dr. Kadai, if you can hear me, can you speak up, please?
Now you hear me? You heard me?
Yeah, I heard you. Yeah, loud and clear, sir.
Yeah, as I told you, so more vitamin D, if it is normal, it will give a protection against prostate cancer. And also, if you have more intake of lycopene that's present in cooked tomato, also may give some protection. And also the pumpkin, also like seeds or it give also healthy prostate.
Doctor, if someone is having the cancer and they are getting its treatment done, so will it affect the sexual life after the treatment?
After
the prostate cancer treatment, will it affect the sexual life?
Yeah, according to the option that has been made. Look, if go to all the options, it may affect the sexual function, but in variable degree. So if we choose, suppose radical prostatectomy, according to his risk group, we can save the nerves that it's adjacent to capsule. As I said, extracapsular, if there is no risk of extracapsular extension, it means the prostate just inside the prostate, we can save that by save the nerves that function, keep the sexual function. So this is important. To see how much the risk of the patient it has prostate inside the prostate and not going outside. So if that inside, we can keep that nerve and we can preserve the function of the nerves, and the patient keep his sexual performance after surgery. Also, radiotherapy, it may affect the hormonal and chemo, all that will affect to variable degree of his performance, but we can improve that by some medicine after treatment.
Thank you, doctor.
Yeah.
Doctor, what are the chances that the cancer has spread beyond my prostate? If so, it's still curable?
Look, what I am saying, that most important to detect it early as much as we can by screening, by this issue. If it is inside the prostate, high chance of a cure. If it is locally advanced, it means go to the lymph node, or it is behind outside the capsule. There is still be cure, but it go maybe less than 50% the cure. But if it is confined to the prostate, it is highly curable. It reaches 90 to 100%, especially in early stage. So especially if you choose radical prostatectomy, we can cure the patient completely. But if it go every step, the prostate will be outside the capsule. It may not confine the cure, it will be less. And if it go to lymph node or to the metastasis systematically, it will, at this stage, definitely it will not be curable. So this is the importance of early detection, early screening, especially in these risk groups, to detect it early and manage accordingly.
Okay, thank you, doctor.
No.
Folks, do you have any questions?
Guys, please have your questions because we cannot travel to Dubai to ask them directly. So there's a chance you get a question directly for free. So please take this chance.
Sorry. There's a particular doctor that wants to ask a question. I don't know if he has asked his question. Dr. Kadai, are you online? Please go ahead to ask your question from Dr. Muthanna.
Yeah.
Okay, thank you, doctor.
Thank you.
We are really glad that you could take time out and conduct the much needed webinar on prostate cancer.
Yeah.
And
I hope that I give you a short brief about the outline of the management of the penile enlargement and the prostate cancer. Thank you.
Thank you, doctor.
Hello.